Welcome to the CPD course titled Australian Neonatal Jaundice and Phototherapy Guidelines, Nomogram Interpretation, Testing Accuracy and Best Practice Care. This 1-hour accredited course is designed to enhance your clinical confidence in recognizing, assessing, and managing jaundice in newborns using current Australian best practice guidelines. By the end of this training, you'll be able to plot bilirubin levels accurately, initiate phototherapy with confidence, and recognize red flags that require urgent escalation. Who should take this course? This course is ideal for all healthcare professionals who care for neonates, whether in urban hospitals or remote clinics. It's especially relevant for registered nurses, midwives, NICU and paediatric staff, clinical educators, and rural health workers. General practitioners involved in newborn care, especially in the first few days of life, will also benefit. If you are part of the team monitoring or advising on jaundice, this course is for you. Well, why this course matters: neonatal jaundice is common, but it can be life-altering if mismanaged. Bilirubin misinterpretation can lead to kernicterus, a rare but devastating brain injury. This course will teach you to interpret bilirubin nomograms correctly, understand when to start or stop phototherapy, and distinguish between physiological and pathological jaundice. We'll also review safe use of TCB and SBR testing and how to communicate clearly with parents. What is neonatal jaundice? Neonatal jaundice is the yellowing of a newborn's skin and eyes due to elevated bilirubin. This happens because the immature liver processes bilirubin more slowly. It's incredibly common, affecting about 60% of full-term babies and 80% of preterm infants. Although usually harmless, close monitoring is essential. The key is knowing when jaundice is physiological and when it indicates a problem. Types of jaundice. There are two major types of neonatal jaundice. Physiological jaundice is normal. It appears after 24 hours, peaks around day 3 to 5, and resolves within 2 weeks. In contrast, pathological jaundice occurs within the first 24 hours or lasts longer than expected. Pathological jaundice may signal infections, enzyme deficiencies like G6PD, or blood group incompatibilities. These require urgent investigation. Risk factors for severe jaundice. Several factors increase the risk of severe jaundice. Prematurity is a major one. The earlier the baby is born, the less efficient the liver is. Other factors include significant bruising from birth trauma, G6PD deficiency, blood group incompatibility, sepsis, and poor feeding. When risk factors are present, treatment thresholds are lower, meaning you should intervene earlier. Why early recognition is crucial. Kernicterus is rare in Australia, but it still happens. That's why early recognition and intervention are vital. Don't rely solely on visual checks. Bilirubin must be measured. Phototherapy is highly effective when started early. Delays, however, can lead to irreversible brain injury. Bilirubin nomogram interpretation and thresholds. Australian bilirubin nomograms are used to decide when to start treatment. Nomograms differ slightly between states, but all are based on plotting bilirubin levels against the baby's age in hours. Term and preterm infants have different thresholds. Avoiding common errors when using nomograms is critical because plotting mistakes can delay care. How to use a nomogram. First, calculate the baby's age precisely in hours, not just by days. Second, choose the correct chart, term versus preterm. Then plot the bilirubin level in micromoles per litre. If the point is on or above the treatment line, phototherapy is indicated. Some states include an exchange transfusion line. This shows when escalation is required. Common plotting errors. Common errors can cause harmful delays. These include using the wrong chart, plotting age in days instead of hours, confusing units like milligrams per deciliter and micromoles per litre, or forgetting to adjust for risk factors. Never rely on visual jaundice alone. Always use a bilirubin test and plot it accurately. TCB versus SBR, accuracy, limitations, and clinical use. Transcutaneous bilirubin, or TCB, is a fast, non-invasive way to estimate bilirubin. It uses a light device placed on the skin. Serum bilirubin, or SBR, is a blood test and is considered the gold standard. Both methods are used in Australia, but knowing when to use each is essential. When to use each test, use TCB in, term babies before phototherapy starts. However, if the reading is close to the threshold, or if the baby is premature, unwell, or already under lights, switch to an SBR. SBR is also necessary after stopping phototherapy to monitor for rebound. Limitations of TCB, accuracy drops after phototherapy or in babies with dark skin. Even the device model matters. Accuracy can vary slightly between brands. Always document where you took the reading, covered versus uncovered skin. In all high-risk babies, rely on SBR testing to be safe. Phototherapy in practice, hospital and home care. Phototherapy uses blue or blue-green light to break bilirubin down. In hospitals, overhead lamps are used. At home, fibre optic blankets or pads may be appropriate. This module covers when to start, how to monitor, and when to stop, both in hospitals and home settings. Starting phototherapy. Start phototherapy when bilirubin approaches the treatment line, not after it's crossed. Gestational age, age in hours, and presence of risk factors all influence this decision. Delaying treatment increases the chance of rebound or escalation. Monitoring and stopping phototherapy. Monitor bilirubin levels at least every 24 hours during treatment. Support hydration. Feeding helps bilirubin excretion. Stop phototherapy when levels drop below the threshold and recheck in 12 to 18 hours to prevent rebound. Then home phototherapy essentials. Home phototherapy can work for stable, term babies with mild jaundice. Educate parents thoroughly on using the device, feeding routines, and red flags. A nurse or doctor must review the baby daily. Clear instructions and safety nets are key to avoiding complications. Red flags and emergency escalation. Signs of acute bilirubin encephalopathy are a medical emergency. Watch for lethargy, poor feeding, high-pitched cries, stiffness or floppiness, and seizures. Act immediately. The baby may need an exchange transfusion. When to escalate urgently. Escalate care when the total serum bilirubin approaches or reaches the exchange line, or if it's rising rapidly. Call neonatal retrieval immediately and start intensive phototherapy while preparing for transfer. Coordinate with the blood bank and NICU early to avoid delays. End of course summary. Let's recap. Neonatal jaundice is common but can be dangerous. Know the difference between physiological and pathological types. Use Australian nomograms accurately. Know when to start and stop phototherapy and when to escalate. Use TCB and SBR appropriately, educate parents well, and follow evidence-based protocols for safer care. Thank you for completing this course. You are now better equipped to provide high-quality jaundice management for newborns in your care.